Royal Highness Prince and all panelists for wonderful session. Next is a session for prioritizing access to the healthcare service. I would like to invite the moderator, Madame Teddy, South Sudan National Mine Action Authority Program Director, and victim expert, and all panelists to please take their place on the podium. I would like to inform that the regional facilitator, please send your note to the ISU team, Mr. Firo Ali Nada. If you don't know, then send to him yet. So your note is really important for the regional discussion. I would like to repeat again, the regional facilitator, please send your note to the ISU, Mr. Firo, if you don't have done yet, because your note is very important for us. And you see outside the room, there are wonderful products that made by our survivor and people with disability. We would like you to visit them and purchase if you can. Thank you.
Hello, hello. I'm testing French. Hello, good afternoon, Awa. We're just making sure you can hear the whole session. Yes? Does it work? Is it working? Change the channel. Cambia canal. Okay. Keep to continue.
Good morning, ladies and gentlemen. You're welcome for this session on prioritizing access to healthcare services. It's a pleasure for me and my panelists to take this privilege so that we can share together the good practices and come up with a concrete recommendation for our action plan. I'm very, very privileged to meet those I've never met before and those that have met before. Thank you. And I want to say, Cambodia, we are very, very privileged to see your country and the good and great things that you have done. And it's a great pleasure for all of you to have this discussion to be something that will give us a success in our next action plan. So to start, it's my pleasure to have this privilege to moderate this session on prioritizing access to health care services. We shall have an interactive discussion as we reflect on some experiences to life-saving tools, approaches, that has been used to reduce fatalities among casualties and to improve access to first aid and long-term healthcare services put in place by the state parties who are government, UN agencies, international NGOs, academia, and landmine survivors' needs and experiences. So this is what we are going to expect from my panelists, the different views, the tools, approaches. Access to health is a fundamental right of every human being, and it's a legal obligation of state parties to ensure there is access to timely, acceptable, affordable healthcare services for all. Therefore, resources must be allocated to progressively realize this goal and ensure appropriate conditions for the enjoyment of health for all without discrimination. Anti-Personnel Mind-Ban Convention acknowledges healthcare as a human right requirement for all and recommends efficient and effective implementation of Oslo Action 33, that is access to healthcare services. We all know landmine survivors, victims, suffer fatal injuries that require quality emergency medical care to prevent, to reduce devastating impacts of death that could be eliminated by immediate healthcare intervention like any other disasters. Most landmine survivors or victims encountered difficulties in accessing first aid and other pre-hospital care in time. That has been one of the significant reasons for fatalities among casualties. Oslo Action 36 seeks to promote efficient, effective healthcare services to all involving landmine survivors, landmine incidences. In most post-conflict countries, landmine and explosive remnants of war contamination is concentrated within hard-to-reach areas where health facilities have been damaged without medical equipment, supplies, and qualified personnel to meet the immediate needs of landmine explosive victims. There is a great concern by the Anti-Personnel Mind-Ban Convention to improve on timely access to pre-hospital care and first aid to reduce the fatality today. Let us have a reflection and lesson learned and concentrate on remote or rural places where there is great need for emergency response and life-saving tools, approaches, and intervention to reduce fatality after explosive incidents at all levels. After the panelists, we shall give floor to other experts to share best practices, lessons learned, challenges, and some key recommendations to make this global conference a success. Affected states and donor governments shall work together in partnership to continue to strengthen capacities of national health policies and strategy to improve the timely access of healthcare services and reduce fatalities due to landmine and explosive remnants of war. At this stage, I would like to welcome our first panelist. Because I don't want to mention a wrong name, I'll just give a brief name. I'll welcome Awa. She is from the Senegal National Mine Action Center. She will be sharing on aspect as a state party. Awa, I'm going to ask you a question that I want you to be answering to the audience what you have done in your country. How is Senegal providing access to emergency health care and ongoing medical care in remote areas of Senegal? So the floor is yours. You're welcome.
Thank you, Teddy. Merci à Teddy, je voulais dire. Je vais parler en français. Je voudrais tout d'abord remercier les organisateurs de cette importante réunion pour nous avoir donné l'opportunité, nous, en tant que Centre national d'action anti-mine au Sénégal. Si je parle des organisateurs, je voudrais dire le centre, l'Autorité nationale de déminage du Cambodge, l'ISU, ainsi que l'Union européenne. Nous vous remercions pour nous avoir donné l'opportunité de partager notre opinion pour l'assistance aux victimes et de vous partager notre expérience dans ce domaine. Donc, pour aborder la question de l'accès aux services de santé, les soins de santé pour nous au Sénégal se résument aux soins d'urgence, les soins médicaux continus, les médicaments et le soutien psychologique. Pour ce qui est des soins d'urgence, il existe un mécanisme de prise en charge des victimes depuis plusieurs années. Il est facilité par des actions entreprises en amont par le CNAMS, notamment la formation d'infirmiers chefs de poste couvrant les zones reculées du pays. Ce mécanisme nous a permis de prendre en charge rapidement les victimes, comme il s'agissait du cas de septembre 2021, avec nos 15 victimes, dont les 5 sont décédées sur le champ. Les 10 ont pu être sauvés grâce à ce mécanisme par la prise en charge rapide des blessés dans les centres dans les postes de commandement des forces de défense et de sécurité avancées. Ensuite, ils ont donné le relais au centre de santé le plus proche et les cas les plus graves ont été acheminés à Ziguinchor où le système est déjà pris en charge par le CNAMS en amont, par les conventions qu'on a déjà signées avec les centres, les hôpitaux de référence. Pour les soins ultérieurs aussi, le même mécanisme est mis en place. Les conventions sont signées avec les hôpitaux et la prise en charge des médicaments pour les victimes de mines qui partent vers les hôpitaux est gratuite et elle est totale. Pour l'instant, je m'en arrête là. Merci.
Thank you very much, Awa, for that intervention in Senegal. I'm going to my next panelist. The hierarchy doesn't matter, they're sitting in the sitting arrangement. Our next panelist is Christelle. She is an officer in charge of United Nations Mine Action Service, office in Geneva, with over 25 years of experience in policy development, advocacy, coalition building. She is a recognized leader within the humanitarian and human rights communities. Before joining UNMAS, she managed resource mobilization and communication for UN Central Emergency Response Fund in New York. And previously, she held position in external relations, interagency coordination, and private sector engagement with the UN Office for Coordination of Humanitarian Affairs. Early in her career, she worked in a joint UN human rights mission in Haiti and as a consultant with the World Health Organization. She holds a master in political science from an institute that I don't want to mention, and the rest. Christine, I want to ask you, what is UNMA's role in victim assistance, and how do you coordinate with partners to address key challenges focusing on healthcare services? You're welcome.
Thank you very much, Debbie. Good morning to all. Like Awa, I would like to thank the organizers and sponsors of this conference. I've listened very attentively to colleagues over the past 2 days, and frankly, we learned so much, and it's going to be very useful for my work. To just a little bit about the UN Mine Action Service role in victim assistance. So we really focus on advocacy and coordination. So for example, last year we worked hard to convince the United Nations to designate a global advocate on persons with disability in conflict and peace-building situations. Two more reasons for this decision. One, we really thought that it would be important for persons with disability to have a role in peace building. And then secondly, what we see in emergencies, in conflicts, is that the issues that persons with disability face in peacetime are actually exacerbated during emergencies. So we really wanted to have an advocate to talk about these issues and try to influence the whole international community, and his name is Giles Dewley. That was the video message that you saw yesterday morning. So that's for the advocacy piece. For the coordination, we have many involvement in coordination at the UN level and also with the UN and NGOs, and we lead a body called the Mine Action Area of Responsibility, which is part of the Global Protection Cluster. And it's focused really much on reducing suffering and casualties from explosive ordnance in emergencies. So we support 16 coordinators in conflict zones to try to improve the coordination in those emergencies, meaning reducing gaps and duplications. So one concrete example of that, in Syria, our coordinator established a victim assistance working group that worked with other actors like the child protection coordinator and also the physical rehabilitation and disability working group. And together they developed a service mapping specialized for persons with disability. And then all the humanitarian partners were able to see, okay, these are the services that are available, and then they could foster referrals of persons with disability and conflict survivors to the right service. I think it's very important. I actually think it's in the Oslo Action Plan, this requirements for service mapping. I really encourage governments to pay attention to that, because often we think there's nothing, but in fact, when you start mapping the services, you realize there is capacity out there. There are local capacity also that are perhaps not known, but the more you know, the more you can address gaps. So that's for the coordination piece. Now, at the global level, we worked a lot on this issue of victim assistance with Elke, who was from HI, who was the co-coordinator of the Mine Action AOR for 2 years. And what we realized is that about 1 in 3 persons who is victim of an explosive ordnance accident does not make it. So you see all the seats next to you that are empty. If they had survived, they would be filled. So how do we address this? And that really bothered me for many, many months. And one day, I was approached by this young lady, Hannah, who works with the University of Washington, and is a surgeon. And Hannah told me, how can I help you? And that's the power of coordination. People hear about it and want to help, and that was very welcome. So I said to her, look, 1 in 3 persons does not survive the accident. How do we change that? How do we make it 1 in 10? That was very ambitious, but Anna was up for it. And Anna started to develop a model and a reflection to see what are the points where we could really make a difference to increase the survival rate. She's going to give you a bit more detail in a second. But the bottom line is that community first aid training is critical, and we think that if governments invested in that, we could really save many more lives. So I will let her explain a little bit more about that. I would just make one last point. As part of this coordination work, we also try to integrate victim assistance projects in humanitarian response plans. And here, this year, for 2023, we had proposed about 40 projects. We is like UN and NGOs that we coordinate, international and local, and in 16 emergencies, and only half of them were funded. So if anybody is interested in funding victim assistance in conflict zones, please reach out to me. I have detailed information about the projects that we have that are not funded yet. Thank you.
Okay, thank you very much. She touched a bit of Hannah, so I'm going to welcome Anna. Anna is a general surgeon, resident at the University of Washington, focused on humanitarian response for civilian casualties in conflict setting. She received an undergraduate degree from Howard University and master's from Stanford University. Prior to her residency, she conducted extensive fieldwork with conflict-affected nomadic population that made her to get an award from the Gate Foundation. And she has been cited by many policymakers, including United Nations Commission on Human Rights in South Sudan. Our current work focuses on improving humanitarian surgical care for civilian casualties in conflict setting, particularly for victims of explosive weapons. In collaboration with the United Nations Mine Action Service, International Blast Injury Research Network, and Pediatric Blast Injury work in partnership with her as she leads the Mine Action Trauma Care and to strengthen collaboration between mine action sector and the victims. So we will hear more from Anna. And as I said, we have heard from government, we have heard from UN, now we are hearing from an academic institution, so let's hear what they are doing. Anna, you're welcome. And your question is, how can actors in mine action sector coordinate with trauma care providers to decrease preventable death and disability among victims of explosive violence or ordinance? You're welcome.
Is this one working? Perfect. Thank you so much, Teddy, for the eloquent introduction, and to my co-panelists for their important perspectives. I deeply admire the work that has been discussed this week to support survivors of landmines and other explosive weapons. The gap that I hope to address, and that our work is designed to address, is that vastly more can be done to address preventable death and disability among civilian victims of explosive incidents in the first place. And further, that the mine action sector is actually extremely well poised to support such efforts. In no way am I advocating that mine action stakeholders should supplant the health sector, because fundamentally this response is the responsibility of local and multilateral stakeholders within health. And yet, due to their networks, capacity, and extensive experience in complex operational environments, actors within mine action are very well poised to develop partnerships with the health sector to mitigate all of the preventable death and disability that occurs among victims. So to that point, some of you heard in a side event yesterday by Stace Pizzino that the current case fatality rate is estimated to be about 40%, just shy of. Thank you for this slide. And that's actually shocking if you contextualize it within mortality rates, even among victims of complex blast injury in military treatment facilities or high-resource civilian practice. It's anywhere from 5 to 8 times higher. That illustrates the fact that much of that death is preventable, and that does not even take into account disability among survivors. So I do confess, when I approached Christelle asking whether we could leverage some novel collaboration, I thought she might have some like tidy review project for me. But instead she came out swinging and asked how we could reduce death from 1 in 3 to 1 in 10. I took the question seriously, and maybe it seems unanswerable, but there are a few different contexts that provide analogy that demonstrate that there's actually a lot we can do. At the outset, one might not seem applicable, and that was the revolution that occurred actually in the United States military's joint trauma system during the wars in Iraq and Afghanistan. Although, obviously, the resource constraints that are experienced in conflict settings in low resource areas are in no way mirrored by a military experience, certain elements are translatable. What I mean is, in order to address the problem of preventable death on the battlefield, is what they called it, the US military conducted longitudinal analyses of casualties, preventable deaths specifically, and found that a large proportion of those deaths occurred in the pre-hospital setting. Although many changes were made to adapt to reduce those deaths, one of the most critical ones was called Tactical Combat Casualty Care, a bit of a mouthful, abbreviated as TCCC. And it's just a fancy name for community first aid training, layperson first responder training. Essentially, every military service member, not just medics, not just individuals with a medical background, every military service member was trained in effective hemorrhage control and management of airway emergencies. And that played a significant role in reducing preventable death by 40% over the course of those wars. Now, again, to sort of argue against the fact that that would not be applicable to a low resource setting, I'd like to bring up the example of the Tromsø Mine Victim Center's initiative, and some of you may be familiar with what they did in the 1990s. Among other things, they had an extraordinarily successful intervention to train lay first responders and pre-hospital providers in landmine-affected areas of Iraq and Cambodia. Over a 5-year period, in a impeccably conducted prospective study that was published in the Journal of Trauma, which is the most respected journal in my field of trauma surgery, they demonstrated that mortality was reduced from 40 to 15%. And that was in the 1990s, however many years ago. So why isn't that being done everywhere? Which really highlights the fact that it's not so much an issue of developing novel tricks or sort of newfangled things, but an implementation problem of how can we implement and scale what is known to be effective. I'm going to sort of skip over a lot of the methodological nitty-gritty in terms of how I approached Christelle's question, but as concisely as possible, I adopted a three-pronged approach. One was a systematic review looking at trauma care interventions in low resource settings with a focus on blast injury. And from that, we structured a framework that was divided into 3 phases. Layperson, so at the community level, before any contact with anyone who has any medical knowledge is made. Pre-hospital, meaning medics, paramedics, individuals with some medical knowledge, and then health facility, which includes everything from a district hospital to a tertiary referral hospital. But because we know that that's not the only issue, and because this is fundamentally designed to integrate mine action with healthcare, we conducted a series of key informant interviews with sector experts in mine action, looking at facilitators and barriers to closer cooperation between mine action stakeholders and emergency health responders. And then finally, we could perform some modeling work using microsimulation techniques with a data scientist to look at how actually what mortality reduction potential could theoretically be achieved through what we're advocating. So through that 3-pronged approach, we came up with a framework for enhanced coordination between actors in the mine action sector and trauma care providers. And that is on this slide here, designated the civilian casualty care chain, with, again, a continuous chain of care from point of injury to the health facility. This is designed to interface with the World Health Organization's emergency care system framework, which is a key form of cooperation with multilateral health actors. And next slide, if you don't mind, modeling what the theoretical impact of implementing that entire chain would be. It's actually a 68% estimated mortality reduction potential, which would theoretically get us from 1 in 3 to 1 in 10. On the basis of this work, we've begun a sort of loose consortium, the Mine Action Trauma Care Collaborative, which is designed to enhance cooperation between mine action and emergency health responders. Last point is that kind of where to start. If you don't mind switching back to the first slide, the framework. Where to start on this entire chain of care, which could take decades to effectively implement and scale. And for many reasons, I would argue layperson first responder trainings. Number one, it's highly evidence-based, it's clear, concrete, and very achievable. Number two, there's actually a lot that we can do to reduce inequity in previous lay first responder trainings, which have been up to 70 or 80% designed for male participants and do not adequately include women and underserved groups. And then finally, once we have a successful pilot implementation, that would be the beginning of clear strategies to scale across other operators in other contexts. And I'm excited that we will preliminarily be partnering with MAG to pilot a joint delivery model between mine action operators and local health actors for layperson first responder trainings in Burkina Faso next year. So I'll conclude there. Thank you all so much.
Thank you very much, Anna. Next, we are going to hear the perspective from an international NGO, that is the Swiss Red Cross in Laos, being presented by Virasak. Virasak is a technical advisor to National Health Insurance Bureau, Ministry of Health, Swiss Red Cross in Laos, PDR. He has worked in this field of social health protection for more than 18 years, and he has contributed technically to the initial pilot of Health Equity Fund for the poor and most vulnerable at the subnational level in the Swiss Red Cross projects. He has progressively achieved, and as we are going to hear, how the National Health Insurance Scheme has facilitated or supported persons with disability and other vulnerable people, because he's still working on the reform to see that there is better financial protection and access to healthcare services. So, Virasak, you're welcome.
Thank you, Teddy. Good morning, everyone. Dear esteemed delegations, and thank you very much for the organizer that allowing me to attend this very important conference. I have learned a lot from all of you during these 2 days, not 2 years, right? And thank you to the lovely moderator and lovely panelists. Yeah, so this is a good opportunity for me to share the experience of Lao PDR in strengthening the health system for better access to healthcare services for the under the national health insurance schemes is a pathway to achieve universal health coverage. We all perceive that access to healthcare is fundamental human rights that every individual entitled to. A person with disability have the same health needs as every other member of the population. They may also have additional or complex health requirements because of their disability or more or consequences of the disability. Accessing to the timely, quality, healthcare information and services are crucial for protecting the rights of persons with disability and all members of the society. The Lao government introduced the National Health Insurance Scheme in 2016 through the government's tax-based subsidies and very minimal co-payment from the population to improve the healthcare financial protection for a large uninsured population, aiming to strengthening the extension of population coverage and the benefit package, contributing to equitable and affordable access to basic healthcare services for all, in particularly for the poor and vulnerable. The ultimate goal is to reduce the financial hardship caused by the catastrophic health expenditures and achieving the universal health coverage by 2025. With the National Health Insurance Scheme, the government has significantly increased the coverage to more than 90% of the entire population in 2020, which significantly improved access to healthcare for the uninsured population and ensure financial protection for essential health benefits for all. However, there's still many challenges to strengthening the health system under the National Health Insurance Scheme system and achieving the universal health coverage. And these challenges relate to the inclusion, financial sustainability, and operation, and the role of the national health insurance in the context of donor transition. And I will highlight the challenges that related to the providing the healthcare services for the most vulnerable group and persons with disability. Despite the healthcare services utilization has greatly increased in general, particularly for women and children under 5 years, but the accessibility to healthcare services for the poor and most vulnerable in rural area, including the person with disability, is very limited. One of the key concerns in this regard is the identification mechanism of the poor and the registration of the person with disability. And ensuring adequate financial protection for the person with disability is still challenging because now in the current system, the co-payment exemption does not include the person with disability, and unless they are identified as a poor, and some services provided is not, for example, the rehabilitation or assistive products are not yet included in the current benefit package. So this is the main challenges for the National Health Insurance Scheme. And now come up with the quality of services especially for the person with disabilities, still insufficient. It is crucial to recognize that people with disabilities have diverse healthcare needs. However, the healthcare services are not designed to these diverse needs. So it's not really reflect to the needs of persons with disability. Most health stations are not designed for accessibility for the person with disability. So it's not friendly for them. And lastly, the number of healthcare workers trained with the knowledge about the person with disability is extremely low. Therefore, the services provided on the ground do not very much reflect to the needs of the person with disability. So this is the major challenges that we are facing now. And thank you very much for your attention. And now I'll leave the floor to Teddy. Thank you.
Thank you very much, Virasak, for that great work that you're doing in Lao, PDR. Now, we are going to hear from Milene. Milene is a professional in social work, and she works in peace and terrorist development, an organization in Colombia where she exercises her leadership and motivates persons with disability, women, caregivers, to accept themselves physically and value the life that they have as persons with disability. So at this moment, we are going to hear from Milene. I don't know if I'm pronouncing the name well. I'm sorry. So Milene, your question is on access to healthcare services. What are your expectations and the experiences in regards to access to basic health care in this situation as a person with disability? You're welcome. Thank you.
Cordial saludo. Sí, señora, soy Milene Ramírez Guevara, una sobreviviente por minas antipersonal desde los 14 años de edad. Nosotros en Colombia, y supongo que a nivel mundial, existen muchas falencias en el tema de la atención en salud, pero estas falencias más que todo han sido desde los territorios, la zona rural, debido a que los profesionales en el área de salud no tienen la suficiente capacidad o especialización en la atención, ya que la mayoría de los puestos de salud en las zonas rurales son enfermeras o médicos generales. Y esto ha conllevado a que muchos sobrevivientes tengan consecuencias de salud, tengan secuelas. Por ejemplo, las personas que somos amputadas, miembro transtibial o transfemoral, sufrimos muchísimo en el tema de la pérdida de la masa muscular y se requiere las terapias constantemente, el cuidado en el muñón, y eso no son accesibles en las zonas rurales. Por más que el médico le mande al sobreviviente o a la persona con discapacidad una remisión, una orden médica, pues hay una barrera en el sentido del transporte, en que donde va a recibir la atención se requiere de un hospedaje, alimentación, del transporte, pero estos no son cubiertos por parte del área de salud del gobierno. Entonces ahí es donde entran en función de la cooperación internacional o ONGs apoyar y a suplir estos gastos que en temas de recursos al gobierno se le ha salido de las manos o no hay suficientes recursos para que todos los sobrevivientes a nivel mundial puedan recibir la atención. Pero más que de la atención en salud, en cuidados médicos, en terapias, en la rehabilitación funcional e integral, es en el tema de mirar la persona como persona de derechos en que puede aportar en la sociedad, en los cambios reales. Por ejemplo, en mi caso, que gracias a la rehabilitación constante, pues pude estudiar y soy una profesional aportando. Pero eso solamente se puede contar con unos sobrevivientes, pero ¿y el resto? ¿Qué ha pasado con el resto? Aquellas personas campesinas, aquellas personas que no conocen palabras técnicas, que no conocen conceptos técnicos, que solamente los conocen son los profesionales especializados. Y también en el tema de intervención psicoemocional, de cuidados y aceptación de cuerpos. Hablo por las mujeres sobrevivientes que cuando sufrimos una amputación, una discapacidad, nos da pena, nos da miedo al tener una relación sexual con nuestras parejas por el simple miedo de que nos rechacen, y supongo yo que así también serían los hombres, porque se fijan solamente en el tema de la salud físicamente, pero no lo emocional del sobreviviente y de la persona con discapacidad. Muchas mujeres y hombres también evitan el poder tener sus parejas estables conyugalmente debido al temor, debido a la timidez de no aceptarse su cuerpo, con amputación, con esquirlas, con aquellas secuelas que nos dejan el trazar de los años, de los meses de esta discapacidad. También en que la atención en salud debe ser tangible, debe ser descentralizado, que no solamente sea en el tema central del país, sino que sea en las zonas rurales. Por ejemplo, en Colombia se vive el tema de que cuando una persona sufre un accidente, ahorita lo vivimos hace poco, una niña de 17 años que estando acá, sufrió un accidente allá en norte de Santander, zona frontera con Venezuela, y la mayoría de los sobrevivientes son rescatados por la misma comunidad que no tiene experiencia en primeros auxilios, y creo que eso sucede a nivel mundial, y que muchas veces por ese desconocimiento genera más consecuencias y secuelas futuras en la persona. Todo lo que es el tema de la atención en salud en segundo y tercer nivel. Necesitamos que sea integral la atención en salud, que sea sostenible, que sea una atención continua, no solamente es en que Mileni sufrió un accidente hoy, la atendemos los primeros 5 meses y después no se vuelve a saber más de las entidades, tanto del gobierno como cooperación internacional. Se requiere que hayan programas, proyectos en temas de atención en salud y que éstas sean sostenibles en el tiempo, pero no solamente en la salud, sino también en el psicoemocional. Nosotros actualmente estamos trabajando con ICBL en un proyecto en norte de Santander, en el que se le realiza a las mujeres la importancia de la aceptación de cuerpos, en los hombres también, porque la mayoría de las personas que sufren una discapacidad a causa de un accidente, muchos hogares hay ruptura familiar debido a esta consecuencia, a esta afectación. Entonces estamos trabajando y invito a todos los presentes de que empiecen a trabajar lo emocional, la aceptación de cuerpo de las personas en condición de discapacidad, ya que esto afecta tanto psicológicamente y emocionalmente, y esto conlleva a que las familias, los niños, las niñas sean afectadas en su entorno laboral, en su entorno de estudio, el tema del bullying que se vive mucho en los niños, en mirar más allá en el tema de los niños, de los jóvenes que son hijos e hijas de personas con discapacidad, porque muchas veces en el entorno estudiantil los otros niños, al ver que el compañerito, la mamá o el papá tiene discapacidad, se genera bullying, se genera aislamiento social. Entonces es mirar las familias, mirar lo conyugal, lo familiar, mirar los hogares. Y en el tema de la salud también mirar ese crecimiento personal de las personas, que por favor se centralice en temas de las zonas rurales. Necesitamos que los puestos de salud hayan personal y hayan equipos de intervención de segundo y tercer nivel, donde en esos territorios que se han presentado numerosas afectaciones, accidentes e incidentes de estos artefactos explosivos, para que así se logre que estas personas en condición de discapacidad sobrevivientes puedan acceder a la atención en salud sin tanta tramitología, sin tantas barreras de acceso, porque ¿cómo es posible que en el tema de los que tenemos prótesis nos digan que es que la prótesis le debe que durar 3 años, 4, 5 años, cuando eso es dependiendo de la vida cotidiana de la persona? No es lo mismo lo que hace una persona en el campo a lo que hace una persona en la ciudad. Entonces necesitamos es que se miren otras herramientas, otras metodologías de inclusión para que así todas las personas que se trasladan en silla de ruedas, que utilizan apoyos técnicos o prótesis, puedan ser incluidos, puedan ser escuchados, pero a su vez puedan participar en los diferentes programas y planes de intervención en salud, para que así podamos todos escucharnos y aportar ideas desde y con los sobrevivientes y personas con discapacidad. Muchas gracias.
Thank you very much, Melin, for being a women champion to support and advocate for the rights of women with disability in Colombia. We are so grateful for the great work that you are doing. I want to ask you another question. In regards to Oslo Action 33, what could be your strong recommendation that you want us to take into consideration as a person with disability?
Creo que ya la mayoría de las personas en condición de discapacidad que hemos estado acá al frente en los panelistas, hemos insistido mucho en que se nos incluya en los diferentes programas y proyectos. Somos personas con habilidades, potencialidades, con conocimiento y experiencia. Somos personas sensibles el cómo llegar hacia los mismos pares. Entonces, sería en que no solamente se nos incluya en la participación, sino en la evaluación y en la ejecución de estos programas, en que sea con enfoques étnicos, con enfoques de género, con enfoques diferenciales y que asimismo seamos incluidos en los diferentes documentos territoriales, nacionales y mundial, en que se pueda compartir experiencias de profesión a profesión y siendo unos profesionales sensibles en el momento de la intervención, de no hacer esa acción con daño, sino una acción fortalecida en que se logre, en que estas personas en condición de discapacidad y los sobrevivientes sean las próximas y los próximos embajadores, los próximos profesionales que estén en las cooperaciones y demás organizaciones para que juntos, entre todos a nivel mundial, personas con discapacidad, personas funcionales, le decimos a aquellas personas que no tienen discapacidad, en que juntos, trabajando en equipo, compartiendo experiencias, logramos un mundo de inclusión, desde los enfoques transversales y descentralizando en todos los territorios y que no se nos quede ninguna persona incluida en esos programas y proyectos. Gracias.
Thank you. I'm back to Virasak. What could be your recommendation as to a way forward to address the challenges that you've mentioned? Welcome.
Thank you, Teddy. I have one concrete recommendation regarding to the inclusive manner. Empower comprehensive inclusion benefit package to ensure the healthcare benefit to address the needs of the specific group that here we mentioned, the victim assistance for the poor and vulnerable and the person with disability. So this is very important and very crucial assistance that could be provided for those most vulnerable group. Thank you.
Thank you. Back to Christelle. What are your recommendations to address the challenges?
Thank you very much, Daddy. Well, I think we just want to request the state parties to strengthen emergency health care and focus on community first aid training. Very simple, it's just taking forward a little bit what we had in the Oslo Action Plan, but just making the investment in order to be able to implement Action 36. Thank you.
Thank you. Awa, what are your recommendations as a state party to the challenges that you've mentioned?
Oui, merci. Nous, pour nos difficultés, notre difficulté majeure, c'est les problèmes de financement. Parce que, comme je vous l'avais dit, le mécanisme existe, mais il faut assurer la pérennité de ces soins. Et pour assurer cette pérennité, il faut le renforcement des capacités des prestataires des soins de santé dans les zones reculées, mais aussi investir dans la formation au premier secours communautaire au cours des 5 prochaines années. Nous, on suggère ça en tant qu'État partie, parce que nous avons constaté que l'assistance aux victimes est délaissée au profit des opérations de déminage. Je vous remercie.
Thank you. Now finally to Anna. From the perspective of the academia, what are your recommendations to address the challenges that we have had? You're welcome.
Thank you, Teddy. I very much agree with Christelle's recommendation, which would be encompassed in mine, and that is that state parties endorse the civilian casualty care chain as a mechanism for improved coordination between stakeholders in humanitarian mine action and trauma care providers in conflict.
I think all these are taken note of. Now want to open the floor. We know we have great experts in the session, and we would like to hear from you, from the NGO perspective, a UN agency, from the government, as well as the persons with disability themselves. I can see 2 hands over there. Some more from this side. It's good if we can take like 3 questions or 4 questions at a time. Yes, you're welcome.
Good morning, everybody. Sorry about that. Obviously, it was far too technical to start the microphone. Quick question for the colleagues from Lao PDR, please, on the role of civil society and ease for civil society and NGOs to operate to fill some of the gaps. You mentioned something about benefit packages, but I would also like to ask you to speak a little bit about the role of civil society and NGOs and challenges that they may have to operate freely and access and provide services. Thank you.
Another question?
For convenience, can I shoot the next one? My name is Keiko, working for the UNDP. Thank you so much. I'd like to ask or make a comment about Hannah's comment and the media's point. I think it's really time for my action of us, for my action actually to go beyond my action. Because we probably stop calling EO risk education. Because what we need to do is not education, but we need to engage the community, empower the community, so they know how to respond, and then they have a planning, even they can do the simulation, and if the incident happens, they are ready. But my action, as we are not quite good at empowering a community, we give them lecture, we give them lessons, but we actually don't empower the community how to plan, how to do by themselves. My other piece of the work involved disaster risk reduction for the disability inclusion, and a lot of the community-based risk management work had been done through that DDR community. So I was thinking, EO is one of the risks, along with a natural disaster or nuclear impact, etc., etc. Maybe there are some activity already there in a community. We can team up with the community. Thank you.
Do you have another one? If we can take 3. Yes, over there.
Muy buenos días a todos y todas. Mi nombre es Alejandra Uzcategui. Yo pertenezco a la campaña colombiana contra minas. En Colombia nosotros tenemos una situación de acceso a servicios, como ya lo comentaba Mileni, un poco compleja, pero quería detenerme en la parte de esa atención de emergencia y de primeros auxilios, y quería preguntar si se está teniendo en cuenta a todas las comunidades, ya que, por ejemplo, en Colombia tenemos comunidades muy diversas, tenemos comunidades indígenas que no hablan el español o que hablan diferentes lenguas, y que sería muy importante tenerlos en cuenta para todo ese proceso de primeros auxilios, porque ellos también tienen sus propias cosmovisiones y tienen mucho que aportar, y que hemos visto casos en los que ocurren accidentes con minas antipersonal. Las comunidades deben trasladarse hasta días para poder acceder a un servicio de salud, y dentro de su propia comunidad se ha hecho todo ese proceso para que ellos puedan sobrevivir, que es precisamente de lo que estamos hablando ahorita. Entonces quería preguntar si se está teniendo en cuenta toda esta diversidad en los territorios y si se están capacitando realmente las personas que pueden aportar en esa atención de emergencia y primeros auxilios. Gracias.
Buenos días.
Okay, the gentleman here.
Okay. Para todos los panelistas aquí y el auditorio, estamos viendo que, primero, mi nombre es David Fernández, soy de Contraminas, Perú. En el tema de asistencia a las víctimas, en el caso de la atención médica oportuna, nos damos cuenta de que está habiendo la falta de difusión. Seguramente no llega la información oportuna a través de los profesionales en las comunidades más alejadas. En el caso peruano, las áreas minadas se encuentran en la zona de frontera, muy cerca de comunidades nativas que tienen idiomas distintos al castellano. Realizamos campañas de educación o sensibilización. ¿Creen ustedes que deberíamos incrementar o mejorar esta difusión? ¿Cómo podríamos hacerlo? Y si a los profesionales de la salud podríamos también invitarlos en su centro de labores y a recibir esta capacitación para que ellos tengan la sensibilización y puedan aportar tal vez ante sus direcciones o sus autoridades, y se pueda contar con un kit, un paquete de asistencia oportuna para estas personas en caso de lesiones severas. Muchas gracias.
Thank you. We'll first give the panelists the opportunity to respond, and then later we shall take another. No. So the first was direct to you. Yes. Then I think the rest you can answer randomly, whoever has an answer to the questions or comments.
Yeah, thank you to your question. Regarding the role of NGO and CSO to involve in the improvement of the benefit packages. So, as long as the currently the national health insurance scheme is the government-led program and is national policy. So the role of NGO and CSO, we currently providing the technical inputs. For instance, some study that related to the accessibility, the inclusive of the service provisions and other information, together with the strengthening in terms of the capacity building, some and health information system. And we also have the technical working group with the WHO, with the World Bank, and with other INGOs. But I think here is not yet included the local CSO that really working with the victim assistance and person with disability. So I think this could be one recommendation that we take into account that to improve in terms of the technical inputs from related CSO, local CSO that really working with in the field of victim assistance and person with disability. Thank you.
This is taller. I can briefly speak to the first question or comment, at least the first part, if I understood you correctly. From our background work, a number of possible strategies for implementing not only layperson first responder training, but other elements of the casualty care chain. But just as you say, it was very natural fit for many to consider layperson first responder trainings as an expansion of existing EORE activities. It's really a very small reach to include, pardon, the types of focused trauma care training that would be providing for community members, which is really designed for hemorrhage control and stabilization of airway emergencies and sort of mangled extremities. So very much agree with that statement. And then I thought it was a very insightful comment from the representative from Colombia regarding the need to include indigenous populations in such trainings. And that's a gap that we'll be addressing specifically. And it's been a very significant weakness of layperson first responder trainings to date. Number one, they haven't adequately included women, only 20% in certain studies. And number two, there has been no exploration of socio-cultural acceptability of the strategies that are used in these trainings, nor of inclusion of underrepresented groups. The analogous population in sub-Saharan Africa, where we'll be focused as a start, would be nomadic pastoralists. And so we'll be specifically conducting baseline needs assessments and focal group discussions to understand methods for inclusion of such populations. But perhaps others have different perspectives to share.
Yes, I'm happy to take the question from the representative of Peru on risk education and the need for greater dissemination. As part of the Mine Action Area of Responsibility Coordination body, we have an advisory group on risk education, which is currently co-chaired by UNICEF and Humanity and Inclusion. And they have a website which is hosted by the Geneva Center for Humanity and Demining. And I take this opportunity to thank Norway for supporting this work. But they have developed a number of trainings and tools on risk education, and they are doing more and more translation. There's online training that are very accessible. Some are for generalists, some are for more specialized staff. So I really encourage your government to translate some of this material in language, that's accessible to indigenous groups in collaboration with them. Then for the other question on, using disaster risk reduction as a model, I think that's a very, very fair point. And I think that some of the delegates who work on convention in Geneva have been talking about moving from a risk education approach to a risk reduction approach that's more comprehensive. And if you look at our recommendation for improving healthcare, it's not just for mine survivors. In many countries, there are many, many victims now of explosive of weapons in populated areas. Many victims also of improvised explosive device, which much more complex emergencies. So all government really in those affected areas need to improve their healthcare service and coverage significantly to deal with this new challenge. And Ambassador Goebel was telling us, or challenging us, to deal with the new challenge, that what is challenging the convention, and we need to evolve and make the right investment. So, thank you.
Ene from Awa and Méline.
Oui, moi je voudrais plutôt ajouter la prise en charge des victimes de mines nécessite beaucoup de moyens. Et les plateaux techniques des centres de santé qui sont dans les zones reculées ne sont pas adéquats pour cette prise en charge. Donc, il faut mettre l'accent sur le renforcement de capacité de ces agents de santé parce qu'il y a très souvent du mouvement dans leur zone parce qu'on les affecte très souvent. Lorsqu'on forme un infirmier chef de poste, par exemple, il reste pendant 3 ou 4 ans, il bouge, il y a un autre qui vient. Il faut toujours continuer le renforcement de capacité. La dotation en kit de trauma pour les soins d'urgence, lorsque le kit est périmé ou que c'est fini, il faut encore renouveler ce kit et cela nécessite des moyens. Donc le nerf de la guerre pour l'assistance aux victimes, c'est toujours les problèmes de ressources et la prise de conscience de ce problème par les autorités de tous les pays concernés par l'action contre les mines. Je vous remercie.
Okay. Méline, do you have something?
Mis argumentos también van enfocados en lo que acabó de decir la señora, en que se debe estar constantemente fortaleciendo y capacitando a esas personas que están en el tema de la salud y que cuando hayan esos cambios de equipo de trabajo, de personal, que se fortalezca estas capacitaciones porque muchas veces, y es lo que sucede en Colombia, que por cambios de administración, de gabinete, alcalde, presidencia o presidente, gobernador, estas personas son removidas de su cargo y entonces ese conocimiento de intervenciones se pierde. Y ahí es donde se empieza a retroceder lo que ya se había avanzado. Entonces sí se necesita que no solamente llegue a realizar en los territorios lejanos talleres de sensibilización en educación en el riesgo de minas, sino también en los primeros auxilios, el de qué hacer en casos que haya una persona accidentada por estos artefactos explosivos y que esto sea constante para seguir fortaleciendo, porque cuando se capacita a una persona y no se vuelve a fortalecer esos conocimientos, pues el conocimiento ya se vuelve en un desconocimiento. Entonces necesitamos que sean continuos tanto el personal del área de salud como aquellas personas, los líderes, los representantes que están con las comunidades en esos territorios. Gracias.
Thank you. Can I inquire if we have to go beyond the time that is scheduled? I need some more time. Sorry? 5 minutes. So I think we are going to round up our presentation, and I'm sorry for those who may have more questions or some lesson learned or experiences. Maybe you can meet us after, and then we can share others if they are so critical. I want to give opportunity to my panelists to finally give their take-home points that they have in just a few seconds. I start with Christelle.
Thank you very much. Well, it's going to be very simple. I'm going to urge the state parties to adhere to the provision of relevant treaties. establish strategies and dedicate resources to implement them, and ensure non-discrimination against and among persons with disability, and committing to a long-term needs and rights of persons with disability. Thank you.
Thank you. Milen, your take-home points.
Antes de dar las recomendaciones, quiero dar las gracias a todo el equipo y todo el personal de logística de Camboya, de la ISO y demás organizaciones, porque nos hemos sentido muy incluidos acá en el hotel, en el país. Pues muchas gracias. Y mis recomendaciones van enfocados en que la atención en salud no solamente sea en primeros auxilios ni funcional, que sea una atención en salud integral, constante, y que sea en el tiempo, para que así se pueda realizar una buena intervención. Y que no solo sea de acompañamiento, sino que también sea de intervención integral y continua, con un seguimiento de monitoreo y evaluación rigurosos por parte de los organismos internacionales, para asimismo revisar el avance y el impacto que estas intervenciones se han implementado en los diferentes territorios del país. También en incrementar la inversión en la asistencia a sobrevivientes por minas antipersonal, porque se han visto muchas falencias que se necesitan mejorar para que así las personas puedan acceder a derechos, de aquellos derechos humanos, derecho internacional humanitario, y que queden plasmados en la acción de Oslo, para que debidamente por medio de esas organizaciones podamos nosotros ser incluidos y asimismo ir avanzando al más allá de esta atención con los sobrevivientes. Gracias.
Thank you. Awa?
Merci. Moi, je voudrais juste réitérer mes recommandations, à savoir faire de l'assistance aux victimes dans les pays affectés une priorité. Parce que ces victimes ont besoin d'être soutenues pour une parfaite inclusion dans la société. C'est un besoin que chaque État doit contribuer à améliorer pour assurer une meilleure prise en charge de ces victimes. Je vous remercie.
Thank you. Anna?
Thank you. My colleagues and I are very committed to supporting your work, and I think that enhanced coordination between mine action and trauma care can address numerous gaps, including some of those mentioned by my colleagues with lack of resource availability and concerns regarding transfer of sort of victim assistance programs in post-conflict settings, and ensuring that those continue through local and multilateral health actors.
Thank you. Virasak?
Yeah, for me, I think that we all have the legal framework. We have the conventions, the guideline, international standard, and every thing on paper that every country can customize to suit with specific conflicts. However, I believe that it's essential to emphasize the importance of policy and try to make it, or try to put it into the practices, to reach the ultimate goal of non-discrimination and leave no one behind. Thank you.
Thank you. I also recommend Anna's presentation on the Mine Action Trauma Collaborative Care to be as one of the side events in the next MSP meeting in Geneva. Because I believe there will be a number of donors that can get in touch with that, so that we can pilot them, especially in most African countries that still have poor access to medical care. And finally, I want to say this. It's been a good discussion, and let's make health a priority for all, irrespective of who gets disability at this moment or in future, let's prioritize access to basic health care for all. I want to thank you, my panelists, and I also want to thank you, my audience, for being patient with us. Thank you, and have a safe trip back home. And I want to say thank you for ISU and EU and Cambodia government. Thank you.
Hello, I don't think you can see me because I'm way back here. Can I? Hello, I just have a couple of announcements. Please bear with me. The first one is to make sure that every person has a a lunch card. The second one has to do with those of you that are departing tonight from Phnom Penh traveling. There is a schedule on top of the table. You need to be by the lobby at 7. That is the only departure for tonight. And then if there is another flight that is at midnight or that you don't see there is a pickup time, please approach the CMA staff, which is handling the travel to the airport. In addition, please, you have to check out, all of you that are staying in the hotel, you have to check out by 2 o'clock, the latest, unless you have a flight in the evening, 21 or 20 o'clock. You can then stay until 6 o'clock, but no later than that. If you have any questions, you can come see us. Then, if you please, I'm going to ask one last thing from all of you. It'll take 2 minutes. Everybody has a notepad in front of you. Can everybody look at your notepads, please, everybody? Just grab the notepad, and in one page, there's a page in there. Just take any blank page, and please write in it what would be your suggestion for a new action plan. What should be taken into consideration, or what is it that you wish you would have had the opportunity to say if you had the microphone or you would have been here? We are asking you to write it, think about it, and leave it on your table. We'll pick them up, and this will be included in the chair's notes. This will be part of the report. When we find that there is many things in common, then that means that something should perhaps be addressed and it can be further discussed. So once again, write on that piece of paper, what do you think should be included in an action plan? What can be improved? What would you like to say if you didn't have the opportunity to say? Any of this. And then last but not least, just a reminder that we have 2 parallel sessions after lunch. One on the socio-economic equity for mine victims in Ballroom 1, right here. And the next one, do more and better planning, reporting, and monitoring in Ballroom 2. After that session ends, we will stay in Ballroom 2. So please do not come back to this ballroom until the very, very end of the day where the closing takes place. We're in the back. Oh, by the way, my name is Laila Rodriguez, and I work with the ISU. And so we're in back there. If you have any questions, I hope that that was clear, but please see me if something is unclear. Thank you very much. Have a good lunch.
Hello? Hi, hello, sorry, I really need to make my comment and I didn't get a chance. I'll write it on the notepad, but...
okay, but people can go to lunch.
Yes, just 30 seconds, but if you want to go to lunch, just go for it. I just wanted to follow on a key point that Christelle and Hannah made about improving care at point of wounding and also later on physical and mental rehabilitation to reduce a lifelong burden of injury. I'm Claudia, I'm doing a PhD on pediatric blast injury and appropriate prosthetics for children that live in challenging environment. Long before I joined my research group, they've been working with people that suffer blast injury, especially UK military personnel, on the long-term consequences that this has held. But then, as they work with them, they recognized that children are very different. They don't wear protective equipment. They're much smaller, and also they interact with the device in a different way that leads to different injuries. So this led to the development of the Pediatric Blast Injury Manual. This is an open source manual that it's available in 6 languages. It was developed by pediatric trauma surgeons that were working in Camp Bastion in Afghanistan. And I think people here are in the best position to make this tool set available so people can use it and we can improve it together. So it's on the Imperial College website, but you can talk to me later. Sorry for keeping you from lunch, but I felt this was important to work together and reduce mortality for children. Thank you, and sorry again.